Okay, and welcome back. Thank you again for attending today's webinar entitled Laser Therapy for Bell's Palsy. My name is David Kanashko. I'm the Director of Education and Research here at Meditech Rehabilitation, and as you may know, we also manufacture BioFlex laser therapy devices. A few housekeeping items. This webinar is being recorded and will be posted on our support page, which is password and username protected, within a week or so of the broadcast. If you have any specific questions during the webinar, please write them down and ask me, and I'll get to them at the very end of the webinar. I also have a skill testing question during the webinar, so feel free to try and answer that question when I ask it, and then I will go over the answer when we're done. And I think that's about it. So Happy New Year, everyone, and let's get started. So I actually wanted to do this topic because I have seen a few patients with Bell's palsy here in the clinic, and the response has been quite remarkable. When we do our trainings here in Toronto and elsewhere, we oftentimes will mention some of these patients as well that we've treated. They tend to respond quite well. When I was doing this webinar, one of our users, Dr. Rob Skleric, also chimed in and showed me a great case study he had. As well, one of our BioFlex users called me just out of the blue, asking me about Bell's palsy, not knowing that I was doing a webinar on it today. So it is a condition that you will more than likely come across at some point during your clinical career. So I'm going to review the anatomy of the facial nerve 7 and the etiology and pathophysiology of this type of palsy, some of the research associated with LLLT and this condition. Surprisingly, there's a few papers on it. As well, how we specifically target Bell's palsy with our equipment, a couple of case studies, including Dr. Rob Skleric's, and time for question and answers at the end. So, as everyone is aware, facial nerve 7, the facial nerve, is a cranial nerve. And this is important to understand the pathway because we do want to treat directly the nerve as much as possible in this condition. So it travels through the temporal bone in what's referred to as the facial canal. I think it's also called the fallopian canal as well. And then it exits at the stylomastoid foramen. It's important to understand where it's located. So you can see here the external auditory meatus. The ear and the earlobe would be roughly about through here. So it's inferior, posterior to the external auditory meatus, essentially in and around the mastoid process. And then you can see the branches of the facial nerve, the temporal branch, zygomatic branch, buccal branch, mandibular branch, and cervical branch. So those are the nerves that will be affected with this type of palsy, and typically it's unilateral, although on occasion it can be bilateral. Each facial nerve supplies the muscles on one side of the face, including those that control the eye, blinking and closing mechanisms, facial expressions such as smiling and frowning, and that is one of the visible symptoms of this condition. The nerve also supplies the lacrimal or tear glands or ducts, the saliva glands, and the muscles of the stapes in the middle ear. It also transmits taste sensations from the tongue, so that can also be altered with this condition. So Bell's palsy, it's also known as idiopathic facial paralysis, is probably the most common cause of unilateral facial paralysis. It was named after Sir Charles Bell, a 19th century Scottish surgeon who first described this condition with respect to the facial nerve and Bell's palsy, or palsy. So as I mentioned, it's one of the most common neurological disorders of the cranial nerves, and it occurs when the nerve is swollen, inflamed, and typically compressed at that foramen as it exits the cranium, and it results in facial weakness or paralysis. As you can see, my reference for this is in white below on this website. So most scientists believe that it's a viral infection. They basically seem to think it's herpes simplex virus, but there's also other possibilities, including viral meningitis, chickenpox or varicella zoster, perhaps some other potential viral causes. But for the most part, it's considered to be a sequelae of herpes simplex virus post-infection. They believe that the facial nerve swells and becomes inflamed, and this ends up causing pressure within this facial canal, or I think it's also referred to as the fallopian canal, or the stylomastoid canal. So let's just review the anatomy again. You can see the stylomastoid foramen is the exit, the hole in and around the mastoid process, and within that bone itself is the facial canal where that nerve is traveling through. So it's this general area that you want to make sure you probe with the laser to affect that area that's quite inflamed and swollen, as well as the branches and the muscles affected, which I'll get to shortly. So other causes potentially of Bell's palsy are genetic factors, autoimmune diseases, trauma affecting the nerve, even tumors of the head and neck can affect it, possibly diabetes, sequelae, and other inflammatory diseases. But they basically believe that most common etiology is herpes simplex virus. Here's my skill testing question. Lots of famous people have, in fact, had Bell's palsy in the past. So here's a young man. You can see some of the drooping of the facial features. And I want you to take a look at this person. It's not me, by the way. It's a famous person. And at the very end, I'll let you know who that is. But if you want to take a stab at guessing, there is no prize. But you will, in fact, if you guess it right, you'll be pretty amazed. All right, so let's move on. So Bell's palsy afflicts about 40,000 Americans per year. You know, stats always seem to be American-based. It affects both men and women equally and can occur at any age. However, it is less common before the age of 15 or after the age of 60. It disproportionately attacks people who have had diabetes or upper respiratory ailments such as the flu or a cold. So perhaps secondary to poor immune response and people getting viral infections, which makes sense because that's what they feel the etiology is. Prognosis-wise, it tends to be very good for the vast majority of these patients. However, it is determined on the extent of the nerve damage as far as how quickly it recovers and the extent of the recovery as well. Improvement tends to be fairly gradual, so it's unusual for a patient to present with it and to be fully recovered in a short time frame, meaning a week or two. However, most of the time they believe that these patients will return to normal functioning within 3 to 6 months of its first presentation. However, for a small percentage, these symptoms can last for much longer periods of time, perhaps even go away and then come back or recur, or sometimes they're actually left with permanent disability, or I shouldn't say disability, permanent nerve damage of the facial nerve. Oh, this is quite rare. Okay, so that's the pathophysiology, etiology, and anatomy, just a bit of a review for everyone out there. Let's look at some of the research on photobiomodulation and this condition. One of the first ones I want to mention is a fairly good randomized control trial. This was, I believe, done in Iran. It was based on 46 patients, definitely skewed towards female than male, 40 and 60 respectively. And they were randomized into two groups, two treatment groups. The first receive what appears to be quadruple LT, but I think that is the triple LT, or low-level laser, or you could say low-level laser light therapy, but it is LLT plus facial exercises. And the second group just received the facial exercises intervention and no laser at all. Wavelength they used was 830 nanometers. Again, I stress wavelengths here because 830 nanometers is one of the peak absorption spectra of cytochrome C oxidase, which is what you're trying to target. The power was about 100 milliwatts, and the frequency in this case was 1,000 hertz, which was very interesting because oftentimes they use continuous wave, but in this particular one they used a much higher frequency of 1,000. So the mean energy density was 10 joules per centimeter squared, and it was administered to these 8 points shown on the diagram on the right, on the affected side of the face, obviously, and the patients were treated 3 times a week for 6 weeks. So notice the points they used This point number 6 is overlying the area where the stylomastoid foramen is. And then you can see the other branches of the facial nerve going into the different regions of the face I showed earlier. So this was just using a laser probe type of device. The rate of facial improvement was evaluated just using the FDI, which is a facial disability index, before the actual treatment began, 3 weeks after the treatment, and a follow-up of 6 weeks after the treatment. And they had quite good findings. I won't go over the details. Certainly, if you want to check out the resource, you can go to PubMed, and the reference is below. Their findings indicated that combined treatment, that is laser therapy with exercise, had the most amount of improvements in the FDI when compared to the exercise therapy alone, which also did show improvement as well. But combining the two had even better effects. So why wouldn't you use laser therapy? Unless, of course, you don't have it. So their conclusion was this treatment modality is painless, without side effects. That's one of the most important things about laser therapy. You can never really hurt your patient or cause any damage, and may be especially useful in cases where corticosteroid treatment is contraindicated. Steroid is usually one of the more common ways of treating this condition. They did, however, mention that they should also look at electrophysiological measurements in order to validate their findings as well. So some type of EMG would have been useful as well. So they felt that was perhaps one of the things they should look at for a subsequent study. Sorry. Okay, the next was just a case study, but I thought it was really interesting and unique. That's why I wanted to present it. And you can see the reference down here below in 2013. And it was on a young person, so a 3-year-old child. This is the first time in any literature that an infant was actually treated with laser therapy for Bell's palsy. In this case, it was a 3-year-old boy. It had sudden onset of facial asymmetry due to an unknown cause. His mother brought the child into the hospital. I think this was out of Brazil. And they concluded that after they screened out other potential causes, that it was some type of facial paralysis, basically diagnosed as Bell's palsy. They used 2 wavelengths here. They used 780 nanometers, again, infrared. They use a continuous wave, so no pulsation, 70 milliwatts. So they treated for about 10 seconds per point with an energy density you can see here of 17.5 centimeters per squared per point during each of the first 4 sessions. And then they did a total of 11 sessions, and at the 5th, 7th, 9th, and 11th, they mixed in a red laser probe as well at 660 nanometers. They basically said they added this to accelerate the neural recovery. So that was interesting, they said that. But it's also interesting, they actually didn't give a power or joules per centimeter squared for the 660 nanometers. But it is important that they added the red, and it's something that we do mention as well when I talk about how we approach treatment. So from the 6th session onwards, they start to actually decrease the output power of the infrared probe from 60 milliwatts down to 50 and then to 40. And this is based on the patient's report as well as clinical observation. So in other words, as the patient was improving, they reduced the dosage subsequently. They recommended that laser therapy should be used as soon as possible. They're even saying within hours following the onset of Bell's palsy. They felt in their clinical experience that the earlier they treat, the faster and the better are the results. And that makes sense because you want to minimize the nerve damage. And we know that laser therapy can definitely help with the physiology of the nerve and the healing of the nerve. So the sooner you do it, and this really goes for any condition, but especially nerves, you will have a much better result. Excuse me. The patient received, as I mentioned earlier, a total of 11 sessions. In the first 2 weeks, there were 4 sessions a week. And then, so a total of 3 weeks of treatment was done in this particular case. The length of the treatment did vary depending on the number of points they used and the power of the per point. So anywhere from 15 to 30 minutes was total treatment time. And the irradiation was applied directly to the facial muscles and the nerves of the lower part of the face or the frontalis to treat the Bell's palsy. Each application, they mentioned, although they didn't show a diagram, were points around the eyes, the mouth, the maxilla, and the other muscles that are innervated by the facial nerve. Very similar to that first study I showed you. The distance between the points tended to be fairly close, so you can imagine hitting one point and then moving it maybe a centimeter or less to the next point. So that's what they're trying to do with their laser probe. Both the wavelength and point selection were adjusted from time to time and seemed to contribute to the patient's improvement. In order to balance between beneficial stimulatory and inhibitory effects, the authors suggested alternating the use of red and infrared wavelength. I think that's really what this comes down to is initially sometimes you want to inhibit pain or you want to inhibit some of the symptoms, in which case a higher dosaging is more beneficial. And then lowering dosages or using red can have more of a stimulatory effect on the healing. So during the first 5 treatment sessions, only the infrared was used, as I mentioned, while the other sessions were carried out alternating the red light as well as the infrared laser light. And again, they mentioned that this was done in order to avoid a plateau effect due to extended use of a single wavelength. Here are the pictures. You can see starting from A all the way down to I. A to B, so here and here, were the first session. C was a third session, and then D the fourth. You can start to see improvement on the E and F the 5th session. G, H, and I were 6th through 8th sessions. So you can see at the beginning A, and then down to H, that was the 7th session, so into the 2nd week. You can see that there's quite marked improvement. And then the J through K was the 9th session, then L through M the 10th, and then basically asymptomatic at the 11th session, N through O. By the way, this was taken from the journal I mentioned earlier, so the pictures were approved for release for in a journal, so that's why the eyes aren't blocked out. Okay, so I thought that was a really interesting case, especially because it was a youngster, and we do use our equipment on adolescents and children and even infants, and this was just a good case of showing you that you can do that. So how do we approach treatment? What we first approach treatment is using our arrays, so our dual plus arrays. And the first placement, we do 2 placements. So the first one would be either above or below the mandibular region, and you basically want to cover the lower 2 to 3 branches of the facial nerve, the external auditory meatus, and the mid to lower portion of the facial nerve. And the second placement would be just above that, again, to get the upper or superior branching nerves. And of course, what you want to make sure is that the patient has their safety goggles on. So not the glasses, but the goggles. And typically the patient is going to hold the array in position. It's only for 10 to 12 minutes, so it's usually the patient's comfortable doing that. The other option would be lying lateral recumbent on the unaffected side and then placing the array over the face and positioning it that way as well. So some treatment tips. Again, as I mentioned, you want to cover the eyes with those blockout goggles during all steps of the treatment, so including the dual array steps and the laser probe steps. You want to use the LDI 200 laser probe anywhere from 4 to 6 minutes, about 5 seconds per point at about 40% power. I'll mention that shortly. And you want to treat in and around the styloid mastoid and facial foramen. So in other words, behind the ear and overlying the mastoid process region. So you can see here is the earlobe. Don't go through the earlobe, go behind the earlobe and around the mastoid process. So that's one of the main areas you want to treat, and along the bone, because some light will penetrate the bone. You can get a bit of light into that foramen and into that canal, the facial canal. And of course, all the exiting branches as well. So as mentioned in one of those papers I mentioned earlier, you want to treat as soon as the symptoms first appear. For stage 1, you want to set the probe at about 30 to 40% power. We do add the LDR 100, and it's quite useful for treating the overlying branches of the facial nerve. Whoops. So those are our treatment tips. So I want to do the first case. This was a 57-year-old female. She came in with relatively acute facial palsy, as you can see here on the diagram. She presented November 23rd, 2015. So you can see a right-sided palsy. The picture on the right was after, I think it was, and I'll show this shortly, 7 or 8 sessions over a fairly short period of time, and we got complete resolution of her palsy. So let's take a look at the protocol. The first treatment, we did 2 placements for 6 minutes each of the dual red. And because it was an acute scenario, we pulsed it out at 50 hertz and 50% duty cycle as opposed to continuous wave. The dual infrared was set at 10 hertz, so much lower frequency than the other paper that used 1,000. And we use a 30% duty cycle, again 6 minutes for each inferior and superior placement, as I showed you earlier. And then we use the probe, again trying to hit all those points that I've talked about earlier, at 40% power for the LDI 200 and 100% power for the red probe, and approximately 6 minutes for each of those probes. So that's the total treatment. Treatments 2 to 3, we then changed. She actually got better, quite a bit better after her first session. We went to continuous wave with the red, the dual plus red, same time frame, and we slightly increased the frequency from 10 to 50 and duty cycle up to 60%, and we kept the probes at the same percent power. And then treatments 4 to 8, so there were a total of 8 treatments, and again that was over about a 2.5 week period, and we pulsed it again at 170, finding a bit of plateauing there, which is why we pulsed it out. We kept the infrared at 50 to 60 and kept the probes at the same percent power. So fairly good response. 8 sessions was all that she needed for good resolution, and I might say that when you add laser therapy, you would definitely get a much quicker resolution to this. And again, we were fortunate that she came in fairly quickly. I don't remember the exact time frame, but would have been within the week of her presenting with those symptoms, and I believe it was within a day or two. The next case is actually, I want to thank Dr. Rob Sklaric, a chiropractor out west in Alberta, for this particular case study. He was nice enough to send it to me and gave me permission to use it. So thanks very much, Dr. Rob. Your new BioFlex system is in the mail right now. Not really. And so let's take a look at his case study. So this gentleman on the right, he had been diagnosed with Bell's palsy. He was a 57-year-old male. On the left side, he had it for about a week, so similar to the case I just presented, and he was immediately started on steroid therapy, and as I mentioned earlier, that's one of the first types of treatments that medical doctors prescribe for this condition. After 5 days, he wasn't seeing any improvement, and you can see the picture of the gentleman here with the left side of facial paralysis. He was also having issues with watering of the eye. As you remember earlier, I mentioned this nerve does innervate the lacrimal glands, tear ducts. He was also having difficulty speaking and a loss of taste sensation. So the treatment consisted, I mentioned he was initially prescribed prednisone. He stopped taking it. Dr. Rob did obviously some cervical spine adjustments because he's a chiropractor, as well as 5 half-hour laser treatments over the mastoid foramen, as well as exiting where the facial nerve exits. I'm sure pretty similar to what I showed you earlier. After the third treatment, Dr. Rob reported that the patient reported feeling twitching in the facial muscles on his left side, whereas prior to that he had not. And he was able to close his left eyelid and was starting to speak and articulate much better. Within 5 treatments, in a period of 8 days, the patient presented with normal facial nerve function, so even better than the results we got here. Good job, Dr. Rob. So let's take a look at this gentleman. After 3 treatments, you can see that there's an improvement of the facial muscle appearance. And then after the 5 treatments, I hope you're charging enough here, Dr. Rob, and all the facial nerve functions are back to normal. So a really great case study by one of our BioFlex users. Again, thanks very much, Dr. Sklarek, for that. Okay, so here we are at the end of our webinar. Who is this person? So let's see if we have any guesses here. I'm going to pull out the guesses if my mouse works. There we go. Let's see if anyone has a guess. Oh my God, someone got it. George Clooney. Excellent guess by, I guess it wasn't a guess, by Jody. Did anyone else get it? Nope, looks like only one person got it. So that is correct. It is well known, or perhaps maybe not well known, that George Clooney did in fact have Bell's palsy as a teenager. There he is there. All right, so thanks for attending our webinar. And if you have any questions, please ask them. Our next certification training date out here in Toronto is on February 23rd, 24th. We're out in Vancouver, March 2nd, 3rd for you folks out in the west of Canada, the United States. If you can join us then, it would be great. And you can see some of the other dates. We're doing a Winnipeg date, which looks like it's spelled wrong. So perhaps we should change that. May the 11th to 12th. We'll be out in Calgary, June 1st, 2nd, Montreal, July 13th, 14th, Saskatoon, October 12th, 13th, and snowy Edmonton, November 9th to 10th. All right, so again, thanks everyone for attending. I'm just going to see if there's any specific questions about the webinar today. Some of the points in the study were close to the eye. Any concerns when using the probe at 100 milliwatts? Is the LR 100 used at 100%? Yes, so the probe is used at 100% for the red. No concerns because as soon as a laser beam, which is coherent, hits the skin, it becomes incoherent. So even though it will appear bright in the eyes of the patient, it's reflections of the photons in the soft tissues, and it won't actually cause any effect on the eyes. To have a laser have an effect on the eyes, the light, coherent light, has to go directly into the eye without the eyelid closed. And so in other words, the coherent light is magnified by the lens of the eye. As soon as you touch tissue around the skin, the orbital region, it is non-coherent and is reflected everywhere in the tissue, and it doesn't pose a risk at all to the patient. All right, well, again, thanks very much for joining, everyone. And we actually have two webinars next month. One is on the personal system. It's more geared towards the general public, but certainly if you, as practitioners, you want to learn a bit about our devices for home care, it would be interesting for you to join us at that date. I believe that's the February 14th or 15th. And then a week later, I'll be doing one in alopecia, or hair loss, and the use of laser therapy. So I look forward to seeing you all there and have a great day. Bye now.